Welcome back to the PFC podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC podcast. This is Dennis, and this episode was recorded with the sponsorship and support of the Special Operations Medical Association. Thank you guys very much, and I hope you enjoyed the talk.
Ladies and gentlemen, good morning. My name is Mike Hetzler, and what I was asked to do was just profile some training programs that are being executed in NATO presently. My disclosure up front is, yes, I'm faculty with University College Cork. University College Cork, or UCC, Security and Defense Medicine program, is in partnership with NATO SOFCOM, most specifically their medical office, also understood as JMed. JMed qualifies and validates all the education requirements for NATO SOFCOM. They support and supply that and facilitate the programs. University College Cork is the academic partner, which comes in and provides the instructors, accredits the entire programs, and then executes the training for them. What the asked was today was just to profile two of our programs that we think are more oriented to irregular warfare and that we are giving in Europe. The first one is an advanced SOFCT course. We do run a single basics SOFCT course, which is 5 days long. And that's basically for team development, damage control evolution, tactical decision-making, operational employment, and in currency and recertification or pre-deployment training. Now, for some of the more mature teams or for some of the more mature and mission requirements, we provide a 10-day advanced SOFCT course. These can be very nation-specific. What we do when the request comes down through JMed to us, we engage with the nation and the specific team. We do a very strict mission analysis and validate exactly what the training goals are. And then we move to set resources and instructors to meet those at the highest possible quality. And basically the ASOST course is to orient the surgical teams out of their comfort zone as much as possible. It's designed to meet both medical support and surgical support to the non-permissive and semi-permissive environments. We drive split team concepts, which Paul had spoken of so eloquently earlier. We drive tactical decision-making, and one of the most primary things that we drive is that understanding and pursuant to commander's intent, and just what that means in the semi-permissive or non-permissive autonomous environment where teams are working on their own. Some of the different goals there, we try to give them different wound patterns from what they're used to seeing. There's a lot less damage control here, and we drive them to minimize kit, but yet look at those more specialized skills that surgeons are going to bring to bear. Vascular care, orthopedic care, neuro care. Where can they make the difference in a semi or non-permissive environment outside of damage control in low visibility operations? We teach them some advanced soldier skills. That way they're not a hindrance or a frustration on the battlefield, and they can actually meet operator and commander expectations there. And then, like I said, we try to minimize kit. We break them down, whether it's electronic and bulky kit, and get them as small as possible, and even thinking about resupply. So this 10-day advanced SOFCT course is one way that we're trying to meet the European requirements in this realm. The second course that is offered through NATO SOFCOM is Advanced Medical Concepts. And to be honest with you, this is the first time we've briefed this outside of Europe. And Advanced Medical Concepts was conceived about 4 years ago. A couple of nations in Europe that were actually sending medics to Fort Bragg for the Special Forces Medical Sergeants course initially said, hey, we need a sustainment at home with proximity in Europe. In addition to that, not long after, nations of Scandinavia and most especially the Baltics came, when NATO SOFCOM was focusing on total comprehensive defense about 4 years ago and said, hey, resistance operating concept was just updated. We need to figure out medical support to the resistance operating concept. And more importantly, what does that mean to Europe? More importantly, what does that mean to each nation? And more importantly, what does that mean to internal development of medical support to resistance operating concept? We conceived of a course, put it together, ran it for the first time in 2023, ran it for a second time here recently, and are planning to run it in next year as well. Basically, It's not a skills course. We are not giving an 18 Delta skills course here. It's a concepts course. What we want the students to do is leave after 3 weeks' time, fully understanding what the medical, operational, and security requirements to internal development of medical support to the resistance operating concept. Our 3 action verbs are basically, do they understand the requirements? Do they appreciate the requirements? And are they familiar with the requirements? Every nation in Europe is absolutely different when it comes to medical traditions, regulations, protocols, scopes of practice, etc. Nobody can provide a one-size-fits-all. But if you understand the requirement, just like Paul's slide, if you understand the requirement, then go back to your nation and solve the problem yourself, because every nation's solution is going to be a little bit different. Again, it's a 3-week course on building block methodology. First week, we hit them in a rural type of environment. What does medical support to resistance operations mean in the rural environment? We start them at basic pain management and sedation levels. When it comes to anesthesia, local anesthesia, and analgesia, we give them the basic surgical skills of instrumentalization, perioperative dynamics, primary closure, wound debridement, washouts, and wound bandage therapy per Robin Copeland's methodology. Second week, we build on that. Again, in first week 2, we drive critical skills such as ultrasound. We consider ultrasound to be a critical piece of kit in this environment. So in the first week, all the students are brought to the same level when it comes to an EFAST and skeletal continuity with ultrasound. We build on that, for example, in the second week, because we want them to understand peripheral nerve blocks, what the potential is in peripheral nerve blocks, and just how to identify that anatomy, at the most basic level. Again, we are not building SEALs here. We are not giving anybody a capability, but they do understand what the advantages are of peripheral nerve blocks in extremity surgery compared to just sedation protocols or TIVA. We drive security throughout the entire thing, and students are very often challenged in their exercises. We do 5 days of didactics and practical application, and then at the end of the week, over Friday and Saturday, they do a 24-hour exercise. Again, first week rural, second week medical, and then third week is in the guerrilla warfare environment. One good thing about working at the university is in design of the program is live tissue, but also we have access to the cadaver lab. And for the first time ever, we had the cadaver lab actually run for 36 hours straight as teams of students rotated in and conducted procedures, everything from a debridement or fasciitis to debridements to below knee amputations, knee disarticulations, and then above knee amputations. We drive rehabilitation very seriously in the very first week, and that was a wake-up call through both of our courses, because several nations never thought about, hey, there's no replacements in the resistance, there's no replacements in guerrilla warfare. We have to get those guys back out on the line and supporting the commander again. So we hit them with rehabilitation skills and methodology and concepts in the very first week. Again, cadaver lab work, again, driving that aseptic technique and those clinical standards, no matter where they are, in order to drive that discipline and set the standard and example for the rest of their lives. Whatever they do in the course, our goal is to set the clinical standard and set the operational standard. That way, through those experiences, they'll never forget them and they'll always strive for those. Again, when it comes to medical evacuation or security methodology in patient evacuation, patient handoffs, patient drop-offs, they get experience in this, in just reasons for purpose, reasons for status, is this type of considerations. At the end of the course, and some of our instructors are here, thankfully, we move to that guerrilla operations. We drive them underground to make sure that they understand that's the most immune place that they could possibly operate in today's battlefield. They do a slaughter class. They do preventive medicine now. And then again, we drive them underground, and they are tasked and given 6 hours to prepare 4 functional areas of a guerrilla hospital, and man those 4 functional areas with a senior medical officer in command, and then they rotate those 4 functional areas 3 hours every rotation. All of our instructors, this is a key lesson we learned from Swedish Remedy, all the instructors are basically hand-selected and invited, not only for expertise and experience, but most importantly, for personality. because bringing a clinician in for 1 week takes him out of the hospital. It takes away from his personal time, his family time, and we want to have the biggest impact both for the instructor and for the student in the course in the brief time that they are actually there. But at the end of the day, they run a Guerrilla hospital for 24 hours with several mass housed and receiving several patients every 3 hours, and they have to manage that throughout the entire time. Again, some of the learning points from this have been rehabilitation, those critical equipment, and the students are very participatory and contributory in this manner. Ultrasound has been identified as a key piece of kit, and we've had students come back from the first course and say, hey, my command is actually budgeting for ultrasound equipment for medics now because I brought this experience back for us. And then learning a great deal about what the European requirement is, not the North American requirement. North American requirements for external support to unconventional warfare are completely different than European requirements for internal medical support to resistance warfare. And that concludes my brief, and we'll take some questions at the end.
That's it for today's podcast. Make sure to go to our website, www.prolongedfieldcare.org. Check out our free downloads and a ton of other helpful information. Grab a bag of our fresh roasted PFC coffee, links in the description below, and stay on the bleeding edge of combat and austere medicine. This is Dennis for the PFC podcast. Out.